Good afternoon, everyone. My name is Lisa Tobe. I'd like to welcome you to our panel today. I am so excited to be presenting on this panel today with youth and adult vaccines. I am a public health practitioner that's been in practice for about 30 years, originally from Louisville, Kentucky, used to run the Center for Health Equity and now run Wildflower Consulting. A lot of my work is based in equity across the United States, and a lot of it has been focused on COVID-19 and the recent vaccinations. I want to introduce you to our panel today. We have three amazing guests, Amy Herrington being the first. She's a clinical educator for the Immunization Branch manager in the Division of Epidemiology at the Kentucky Department of Public Health. Prior to her current role, she was assistant professor in the School of Nursing at the University of St. Augustine for Health Sciences. Her academic and research focus at USAHS was interprofessional collaboration and education as her driving force for improving academic and clinical outcomes. Dr. Herrington has over 30 years of combined nursing, academic, and research experience. She's a certified nurse educator and certified emergency nurse. Thank you so much for being on the panel. I'm going to introduce the other two folks before you get started. The second presenter will be Dr. Brian Krueger. He, after earning a PhD in political sciences from the University of Notre Dame, Professor Krueger joined the University of Rhode Island faculty in 2011 and now serves as the Associate Dean of the College in Arts and Sciences. A well-known scholar on his work of public opinion, political behavior, emotional role in regulating activities, new media and trust, and government surveillance, the American Political Science Association has awarded him several national competitive awards for his research. Next, I'd like to introduce you to your final panelist. It'll be Molly Lewis. She's a Chief Operating Officer for the Kentucky Primary Care Association. Molly previously has held multiple roles at the Commonwealth of Kentucky Cabinet for Health and Family Services, including Deputy General Counsel, Executive Director of the Office of Health Policy, and Deputy Inspector General. The Office of Inspector General is the regulatory and licensing agency for all healthcare, daycare, and long-term care facilities and child adoption, child placement agencies in the Commonwealth. She practiced healthcare law as associate attorney for McBrayer, McGinnis, Leslie, and Kirkland, PLLC, for 8 years in Lexington. And I would like to go ahead and start our panel. Amy, would you take it over, please?
Absolutely. Thank you so much. I'm going to share my screen now. And what we're going to talk about today is childhood and adolescent vaccinations. So what I'd like to begin with is talking about vaccinations that are happening outside of COVID. What we know is that the CDC estimates the vaccination of children born between 1994 and 2018 prevent 490 million diseases and help avoid 936,000 deaths and save our healthcare system, our societal costs, $1.9 trillion. So overall, vaccine preventable diseases is profoundly important individually, to a community and to our country. So as we begin to look at that, we need to talk about the Vaccine for Children's program. And I'm going to focus on that because for the Kentucky Department of Public Health, that's where our data comes from, is the Vaccine for Children's program. And what that program is a federally funded program that provides vaccine at no cost to children who would otherwise not be able to be vaccinated because of an inability to pay. The CDC buys the vaccine at a discounted rate and then provides those vaccines to the Kentucky Department of Public Health. And the Kentucky Department of Public Health then distributes those to providers that have agreed to join the program, the Vaccine for Children's program. And so the children that are eligible are entitled to receive these vaccines through the system at no cost. So what does eligibility look like for those children? Well, those individuals are Medicaid eligible children. Those children are from uninsured or underinsured families. They're American Indian or Alaska Native, and they are primarily receiving care, not always, but primarily receiving care through a federally qualified health center or rural health clinic. And so those are our primary VFC providers. Others are eligible. So when we begin to talk about the data that we receive and how we evaluate the efficacy and effectiveness of our program, we need to recognize that the data is collected through the VFC system, because as a grant-funded program, we must evaluate outcomes, and those outcomes are the number of vaccines that were provided. Now, some private healthcare providers do contribute, but it's not a mandatory contribution or for those individuals, but it is mandatory to report data if you're a VFC provider. We're hoping that as individuals become COVID providers, and they're used to using the system and reporting their COVID vaccine data, that will increase the number of reports that we're receiving from private providers. So we'll continue to monitor that closely. Currently, if we look at our data, we see that in 2019, this is an aggregate of all vaccines administered in Kentucky. So we were here at 250,000. We dipped off a little bit in 2020 as we saw that well visits were held and schools weren't in session. And we're beginning to improve here in 2021, but haven't made it back to that 2019 level where we were previously. In looking at just DTaP, TD, Tdap, and changes from 2020 to 2021, this slide represents the percentage change between those 2 years. So if we look specifically in the 7 to 13 age range, you can see there was a huge increase in April. And so we know that that increase in April is directly related to, in 2020, we had a huge hit, a huge decline in well child visits. As you all remember, we didn't want well children in doctor's offices for those visits, so we held off at that point in time. So we had a large decline in 2020 in April of 2020. So this year we have a huge increase, and that's the balance. So you look across the screen, you can see the changes that we've seen in the percentage of individuals vaccinated between 2020 and 2021. Where we're struggling to get back on track really is that 7 to 18, that school age range. And so if you look at all doses administered in the 7 to 13 age range and then the 14 to 18 age range, the blue line represents 2019 and the red line represents 2020. And then the green line, we still aren't back up to our 2019 doses administered. And the same is for this school age 14 to 18 age range. In our 20 to 20, that's the teal colored line, and our red is just slightly above that, but nowhere close to where we were in 2019. What we know is that as we focus on vaccination recovery post-pandemic, we can see that school-age children, and particularly adolescents, really haven't recovered well. What we know is adherence to state regulation is driven by school district policy. And we believe that presence of a school nurse really impacts vaccination rates. We also recognize that at times, though vaccine is required by the school district has to make the decision about excluding a child from the school if they aren't caught up on a tetanus shot, for example, because that may impact food insecurity. And so the school district must balance those social concerns as well as the safety of their population. When looking at these numbers, we see that as really apparent. This data looks at coverage vaccination in that age of 13 to 17 years old. And this is from the National Immunization Survey. So it looks at not only Vaccine for Children program, but also private providers, because this is driven by the CDC. So what we see here is that over the years, the early vaccines, the vaccines that are regulated and required for school attendance, we have steadily increased. One of the areas that is recommended but not required for school attendance that I'd like for you to pay particular attention to is this HPV. And so what we see in the HPV, which is the blue, pink, and green lines, is we have a higher vaccination rate amongst our females than males, because human papillomavirus is still seen as a female disease and not a man's disease. The balance here is seen with the pink line. Though we have some overall increase in 2020, we still really aren't where we need to. And then the focus on how our populations respond to HPV is still a work in progress. So as we look at this data, we need to talk really about why KYR, or that Kentucky Immunization Registry, is important. It provides us data, as I've shared with you, on vaccination rates. While it's mandatory for our vulnerable populations, we would really like to be able to see data across the board from all private providers. And as we have began to offer the COVID population, the COVID vaccine to multiple populations, then providers have been entering that information in the KYR. So that pattern of behavior is building. So we're hoping, as we transition to regular standard recommended the vaccinations and less pandemic driven vaccinations, those practices remain in place so we can still get data from primary care providers. We also get data from pharmacies. We also get data from schools, hospitals, nurses, and nursing homes. Now I want to transition just a little bit to the COVID vaccine. And so I'm going to click here on our COVID vaccine dashboard, and I want to share with you this great information that we have. So this is ky.covid.gov. And if you click on vaccine and scroll down to view dashboard, you'll see a picture of the state. And what you're able to do with our updated dashboard, which is really, really exciting, is you can click on a county, and the county will provide you here in this left-hand column the percentage of population that has been vaccinated with the COVID-19 vaccine. And as you see, in the age of 65 and above, we're really doing great. 83% here in Hopkins County. But of the 12 to 17 age range, we're at 30%. So that's our school age children. And as you move up to the 18 to 29 age range, 40%, and then 30 to 39, 45%. So this gives you a great snapshot of vaccination rates county by county. This helps health departments as well as providers know who to target the messaging to, and helps us as a state begin to look at areas that we can really focus our efforts. If we look here in Shelby County, we see that 12 to 17% of their, in the 12 to 17 age range, 47% of their of that population is vaccinated, as opposed to the age 65 and above, which is 77%. So this is a great tool that we've been using in order to help design our outreach. And as we talk about outreach, we need to remember that the Pfizer vaccine can be administered to children 12 and under. And of these COVID vaccines, we need to remember that you can co-administer with the flu shot, with a tetanus shot, with HPV. So as you're bringing those patients in for the regular immunizations, you can offer and administer the COVID vaccine, or if they're presenting with the COVID vaccination, then you can update them on their regularly missed vaccines if they're not on time and need to get caught up. We know that this co-administration is profoundly important because return visits aren't consistently followed. We also know that some people become concerned about getting vaccinated, even though they're told by their provider it's very safe. So co-administration, even within 14 days, is very appropriate. As we talk about vaccines, we have to talk about flu because flu season is here. And so we've seen over the years that we have increasing numbers of individuals that are receiving the vaccination, the flu vaccine, but in that 13 to 17 age range, once again, the vaccination rates for the flu are much lower than they are for the younger children. So what is it that we need to do to increase vaccination with pediatric patients, with adolescents, with children? really having a conversation with the child as well as the parent and asking open-ended questions. We found that having a conversation with a trusted individual is what is leading to those that were less likely to become vaccinated. And with that, having a conversation with the adolescent about their concerns. Paraphrase any information that they're sharing back with you so you can make sure you're restating what their concerns are. If they talk about, I read on the internet, I read on FaceTime, I read on I heard on TikTok, talk about that's a great place to get some information, but not the best place to get vaccine information. So make sure you're supportive while redirecting those individuals to the proper place to get information. Also ask, do you mind if I share this information? Pediatricians have told us, they begin this conversation with, I've known you since you were 2. I'd do everything that I can to keep you safe. Would you mind if I share with you some facts about vaccines? Not only the COVID vaccine, but all vaccines. Respond to questions and concerns in a really judgmental and respectful manner. Some of this redirection, instruction, provision may even lead to discussion about anatomy and physiology because there's so many questions and concerns about how the vaccines really work and is my DNA marked forever. Make sure you're providing accurate information and using tools that the individual you're teaching, whether it's the adolescent or the parent, can easily understand. As we look at health literacy, we need to recognize that the readability level for medical information should really be on that 5th grade reading level. And in some regions, on that 3rd grade readability level. So if we're pulling information directly from a CDC website, we know that those materials are written at a 10th and 11th grade level. So you may need to take those resources and pull out key terms that may be confusing. Because at times, if they don't understand the information, then they're going to ask their friends, their neighbors, their Facebook, and go to TikTok, because those are passive least resistance in order to get the information, the answers to their questions. You need to acknowledge any past bad experiences that individuals have had with the vaccine. You got this flu shot and you felt horrible afterwards. You got the flu shot and you still ended up getting the flu. You had a whole lot of pain in your arm after you had your hepatitis shot or your HPV, and now you don't want to get it. There was a big red spot and it was really sore and you couldn't pitch for your baseball team. You need to recognize those because those are scary occurrences, and acknowledge those so you can continue to build that trusting relationship and really acknowledge uncertainty as we don't know everything at this point in time, but we make decisions with the best available evidence that we're presented with. As you begin to have these conversations, make sure that you're sharing your personal decision. I decided to get the vaccine because. Make sure you share the benefits, protecting themselves, no quarantine at school. Your football team will be able to play. You'll be able to go cheerlead this Friday as you can begin to, spend more time with your friends in that protected and safe environment. So make sure you share the benefits as well as the risks as you have these conversations and answer those questions open and honestly. I've provided lots of resources here to help answer any additional questions, specifically the vaccine tracker information that you can find on the CDC website and look how Kentucky's compared to other states, vaccine information for patients, vaccine finder, because we know that we still have access challenges throughout the state. And though we have vaccines everywhere, many patients don't know where to find them. So the vaccine finder information is really important to share. Lots of resources about talking with patients and how to answer questions, specifically a tool for children and teens. And the CDC has this amazing page about Mythbusters, myths and truths. and what those, how to answer some of those questions that you may be approached with. I really appreciate the opportunity to share this information with you today. Thank you.
Hi, Dr. Herrington. Thank you so much for that conversation and giving us an update on the impact of COVID on other vaccinations, telling us more about the dashboard and ways to effectively use that. I like your conversation about effective outreach and the strategies that you can do to increase vaccination. In particular, I liked when you talked about, I've known you since you were 2. Some of these are really concrete examples of ways people can hold these conversations. So thank you so much. We're going to move on to Dr. Krueger. I gave you a brief introduction of him before, but just prior to COVID-19, Brian and his colleagues from URI's pharmacy department published their research on ways to use communication to overcome vaccine hesitancy among U.S. adults. Brian has also written popular press pieces at outlets such as the Washington Post Monkey Cage, worked as a national CBS News exit poll analyst, and had his research profiled in New York Times. Brian, look forward to hearing what you have to say to us today. Thank you.
Thanks so much for having me. Really appreciate it. I'm just going to put this maximized. Just give me one moment. Let's see if I can get back here. Okay. So thank you again for having me. I think this is a great opportunity to share some information about my own research, and as well as kind of evaluate some of the scientific academic research on vaccine attitudes and messaging. We're going to start by taking the case of measles, because it's very instructive and I think gets us into some of our present day challenges. Throughout the 20th century, we had about 500,000 on average cases of measles per year. As probably most of you know in this audience, it's extremely contagious and also has a pretty high rate of long-term adverse health outcomes as well as death. And by the year 2000, thanks to vaccinations, the World Health Organization declared that it had been eliminated from the United States. It wasn't too long after that, as this large map shows, that we had a number of outbreaks. And 2019 will be the worst case, the worst year in 20 years or more from there. So what do we do about this? And as a scientist, they've commonly approached this from a particular direction. Well, we've eradicated the disease, people forget about it, therefore we need to inform them about it. So as long as we get that right knowledge that measles is a serious disease that can kill you, as long as we say we have an effective vaccine and we let people know that it's safe, then that information should help move the public, right? So those people who were unsure or against the vaccine, they'll get this good new information and they'll replace their current opinions. This doesn't seem to be the case, however. Continuing with the measles example, I think gives us a sense of why this is such a challenge.
Brian?
Yes?
I don't think you're in presenter mode. You might want to double check and see if your slides are moving forward.
I see. I see the slide I'm on. Is that not?
It just moved forward to a different slide, and we can see your slides on the left. So
maybe there's a lag.
Yeah, there could be. Go ahead. I'm sorry to interrupt you.
Fine.
That's fine. On the first slide. So thank you so much.
So here we are. We have the polio Triumph vaccine here, and let me know again if you can't see me again. I'll do this a different way. It does say I'm sharing. One thing we notice when we take a closer look at the measles outbreaks from the last couple of decades is that a very large share, almost half of the overall cases, came from small subpopulations, social groups. And what this is telling us is it's likely that the current vaccine challenge, this attitudinal challenge towards getting vaccines, is likely also embedded as a social identity issue. So this isn't simply about creating the vaccine and getting the right information out there about it. There's something else going on here that's creating these challenges. So let's explore that a little bit. Once an attitude is connected to one's social identity, so if not getting vaccinated is connected to your social identity, that attitude becomes especially sticky. And any type of new factual information can be easily overridden by their existing beliefs, right? These are people's worldviews that connect to exactly who they are, their own self-conception. And rejecting one of those core beliefs would put their in-group standing at risk and also create a lot of self-anxiety about who they are. And it does seem like that vaccine attitudes have become socially structured. So we are experiencing this when we're thinking about vaccination. It's an unfortunate occurrence that it happened. It would be an easier problem to address if it was more randomly distributed throughout the population. So we have these really sticky attitudes. So there's been a number of experimental designs, so high quality studies that have looked at the effects of trying to correct misinformation about vaccines, or just simply what happens when we conduct informational campaigns about vaccines. And some of the results are quite disturbing, because what we found is in many cases, conducting an informational campaign can actually exacerbate the problem. So those that are already holding these anti-vaccination beliefs tend to actually double down rather than see the light. And we've seen this across more than just one study. So this is a finding that has been replicated. Now, I just want to be clear, we're talking about those people that hold that firm belief that's connected to their identity, not necessarily people that have some questions. So a lot of what Amy talked about is absolutely right on best practice. So what I'm talking about are for those people that already hold core beliefs about vaccination, which are negative. And those are the folks who actually will double down, and engaging them could actually be counterproductive when you're talking about trying to correct their misinformation. So that's a window into the social side of these attitudes and why they're so difficult and can be very entrenched and hard to move. When we think about COVID, again, unfortunately, it does appear that COVID vaccination attitudes are also socially structured. So in other words, we have about 4 to 5 times as many Republicans saying that they will definitely not ever get the COVID vaccine compared to Democrats, right? And you have rural residents, white evangelical Christians among that group that's most resistant, and basically saying definitely not at the highest rates, whereas older adults and Democrats, urban residents tend to be most open to COVID vaccination. So these attitudes do appear with COVID to be socially structured. Probably no big surprise to the folks in this audience. One thing that is particularly concerning is it appears that it may be becoming increasingly so. In other words, the rates of polarization, or the rates of difference between subgroups and geographic areas, are growing, not shrinking. So we've had a big rollout, and what we're finding is early on in the COVID vaccine rollout, we had small gaps between those counties that voted for Biden in the last election versus those counties that voted for Trump. As we've progressed, we see that this gap between Trump counties and Biden counties has increased. We also have other evidence that suggests that Republicans who rely most on right-wing news media have actually become increasingly against getting vaccinated as time has gone on over this year. So this polarization and these gaps are growing, and it's showing that, hey, we're embedded in this social environment. Those that are holding these beliefs are often holding it as a core value for who they are and what groups they belong to, and they probably also have many people around them that also feel this way. Thinking about vaccination this way helps us understand why some people are getting vaccinated in secret. There's this report out that people are getting vaccinated wearing disguises. And what this tells us, or why this is interesting, is, when we look through this issue from a social lens, it does tell us that maybe when we're having our clinics, when we're having our locations and our systems for getting vaccinated, and particularly the COVID vaccine, we should make sure that we're thinking about confidentiality and privacy. When I got vaccinated, I was in a long queue. People were there that I knew. It was almost a social event, even though we were 6 feet apart in the line. That's probably not a good idea in areas that have high numbers of people that are clearly against getting vaccinated. They don't want their neighbors, their friends, and families necessarily to know they're getting it. We should build that into our system. I'm an associate dean at a college. We have a number of students who told us, we have a vaccine mandate at the college, that they can't get vaccinated because their parents won't like it. But once they show up on campus, they're going to get vaccinated. Again, this is that social pressure that's there, and we need to be mindful of that as we're creating our policies. So this is a graph of those who've been or are just about ASAP to get vaccinated. That's approximately 70% of the national population right now. You can see this over time going up. Early on, we had nearly 40% of people who said they were going to wait and see about the vaccination. This is your group where messaging and talking to people will work, or at least it may work. This is the group where you really do want to engage the person and do all the best practices that Amy talked about. And you can see that this group has gone way down from about 40% to approximately 10% of the national population. Very interestingly is the definitely not group. Everything else has a trend. The definitely not group has been stuck at 14% across all the polling that's been done on this. And persuasion probably won't work. Talking to that person probably won't work. An informational campaign, media campaign, probably won't work. These are the same folks we're seeing in our experimental studies that I talked about, where they are dug in. They're the definitely not group. And getting vaccine messages to them are not likely to move the needle here. This is a group that will probably only get the vaccine if it's required. And this group could be as high as, this is the national 14%, that's definitely not, but in anyone's local community, that could be 30, 40, 45% of people who are feeling this way. So there's been a little talk about subgroup understanding, so understanding the population we're talking to, and certainly one size type fits all communication is part of the reason why our information campaigns aren't as effective as we would like. And we certainly should be sensitive to the culture and the subpopulations that we are working with. So this gets into a study that I was an author of that considered how could we close the gap in adult pneumococcal vaccination rates between people of color and whites. So there's a gap in actual vaccination rates, and we asked ourselves, could we figure out messaging that would resonate with the BIPOC community and hopefully also resonate with the white community? But we wanted to make sure that the standard messaging we were using wasn't turning off that subgroup that had a lower overall vaccination rate. And I'm not going to go over these in any detail, but basically we did the standard formula of the vaccine is effective. We talked about another treatment group where we told people about the problems with pneumonia. In other words, that it has 50,000 people a year die of pneumonia. There's all these other complications that come from it, and also the safety. So there are multiple control and treatment groups that receive some of these standard messaging. And then we also had a messaging that focused on protection of their community and their families. And we talked about it in terms of duty. Being responsible and caring for those around you means getting vaccinated. It's everyone's duty to eliminate contagious diseases from our communities, these types of messages. So I'm not going to get into the methodology of the design, but basically we evaluated which of these was most effective at changing attitudes in finding the pneumococcal vaccine an important thing for them. And we did this in a survey, and we also did the same experiment that got the same results in a pharmacy in the Northeast. What we found, very interestingly, is that this community and duty message, this family and community message, was clearly the number one message that would increase positive attitudes towards vaccination. And we learned a few other things. If our communication campaigns are heavily focused on things like the fact that it just prevents pneumonia or that it is a very safe vaccine, those tend to have greater impacts on the white community than on the BIPOC community. So if that was the core of our vaccine information message, it wouldn't bring everyone, it wouldn't lift all boats at the same rate. Whereas when we use this community and family duty message, what we find is that really resonates across all communities. This is what we found for our specific purpose of focusing on this adult vaccine. But you can think about this in a broader term where you need to know who your audience is. And when you're communicating with them, you want to make sure you're talking about things that resonate with them. That's why some of Amy's suggestions about asking questions first can be really effective on a one-on-one communication. Whereas we were thinking more about information campaigns, so larger media type approaches. And this is my final slide. When we look into COVID, so returning back to COVID again, there is some evidence, although not using the same rigorous experimental designs of some of the other research mentioned in my talk, there is some evidence that this community-based message is the most powerful message. So this was a survey that asked them, would you be more likely to get vaccinated if you knew about various things? And the hesitant and the refusers in yellow and red respectively, you can see that we're protecting others' human lives, right? Not themselves. You're protecting the most vulnerable people in your community, etc. Those are things that do tend to resonate with the hesitant. These are people that have questions. With the refusers, you're really only looking at 1 out of 10, 1 out of 15, 1 out of 20 individuals that might come around, even using that messaging, right? Again, messaging has its limits. So this could be an effective talking about the elderly with the vaccine efficacy waning, children under 12, others that are unable to be vaccinated. Those are the messaging that would likely bring people most around to rethinking whether they would get the vaccine. Thank you for your time. Really appreciate you inviting me here.
Thank you so much for that presentation. I really think it was eye-opening in so many ways, talking about doubling down, talking about how it's social identity based and creating some more solutions, including confidentiality among certain folks who might get it. So I really appreciate you giving us some concrete examples of things that we might think about and work with in Kentucky and nationally. I'm going to go ahead and move on to our last panel presenter. And I also encourage the audience to go ahead and put any questions you have in the Q&A part. We'll do that at the end to any of the panelists. So Molly Lewis is going to join us. She's the Chief Operating Officer for the Kentucky Primary Care Association, which is a membership organization dedicated to promoting access to comprehensive, community-oriented primary health care services for underserved populations across Kentucky. Molly plans, develops, organizes, evaluates, and promotes daily independent practice association and association operations and activities at the direction of the Chief Executive Officer. Molly, I really appreciate you joining us today and look forward to what you have to teach us.
Thank you so much for having us. I'm Molly Lewis. I'm with the Kentucky Primary Care Association and really appreciate being invited to speak with you all. We are, as Lisa said, a statewide trade association, and we're designed to promote wellness and prevent illness in Kentucky. So our mission is to promote access to comprehensive, community-oriented primary health care services for the underserved. And it really helps to think about what is the underserved. What the federal government has designated as an MUA, which is a medically underserved area, or a Kpca, which is a health professional shortage area, are areas where healthcare is not easily accessible. And this does not mean that the health providers that are located there are providers of least resort. or last resort, but rather they're located in areas where healthcare needs additional supports. And so what we try and do is leverage resources and support the health centers so that they can be successful. Wait, did I skip one? Okay, so this is who our providers are. The Kpca primary care providers are patients, our members are those who have the unifying theme that they provide comprehensive medical homes. So a lot of times it's more than just providing primary care. It's also providing an on-site dental clinic, an on-site pharmacy, transportation, access to behavioral health services, being located also in the nearby school setting, to provide education. So this model is devoted and designed to overcome barriers that otherwise might prevent access to healthcare, and to really become part of the community. Lately, this has shifted to also using community health workers to help navigate the community health system. And because we've found that when patients trust their health system, they'll return, and that provides comprehensive, continuous health care. With that, I think that we were asked earlier to kind of think about what is necessary to help address the vaccine challenges that we're currently experiencing. And I think Kpca really clings to the idea of using its partners. And this is just a small sampling of who our partners are. And we appreciate the work we have with the Foundation for Healthy Kentucky and with Dr. Herrington's group at Public Health and everybody to come together and determine what the solutions are. Our members are located across the state. This image shows that we have over 300 locations. We have about 27 federally qualified health centers, and also about 90 rural health clinics. And then we also have what would be more traditional primary care provider. And so you'll see from this map that we're located in counties that don't have hospitals, and we are located in kind of all the nooks and crannies of Kentucky to help provide access to care. Our membership, the providers who are within our membership, take care of about 20% of Kentucky's Medicaid population. It's also interesting to note that while on a national level, rural health is declining and there are less rural health providers now than there were before, the opposite has happened in Kentucky, and we are having more and more rural health providers and providers that are able to go into rural areas to deliver care. And a lot of the same tools and strategies that make a health provider successful in a rural area is similar to the urban areas in terms of having to take care of the whole patient. So our clinics, in providing these services, that prevent illness and promote wellness, immunizations are a natural part of that. And it's something that's been going on for decades. This COVID vaccine is not something new. And as you know, or as a parent or as an individual or as a child to a senior, we all know that you need access points in order to get vaccines. And we maintain that the primary health care provider is a good access point. As Dr. Richardson said earlier in the presentation it's not the only access point, but it is one that needs to be part of taking care of the whole patient. So what we do to support our members' delivery of vaccines is with help with the operations or whatever is needed to support the clinics, so that the providers we help the providers provide healthcare. And so a lot of times it's helping to get the shipment of the vaccine, or getting the refrigeration for the vaccine, or having access to a smaller dose, being able to break up those large bundles that initially were available for the COVID vaccine. Also learning how to code for them, or to bill, or how to be reimbursed. Also, we partner with organizations that help with sending out reminders, those happy birthday cards that come for a first year birthday saying, just a reminder, this is a good time to check in with your doctor. And at that visit, obviously, a vaccine will be part of it. With respect to COVID, our members have been creative and they've been innovative in what they have done to meet the needs of their community. And I think that what has been successful and what we really promote from our members is to know their community. Community health centers, it's a federal requirement that they have community members and patients on their boards. And rural health clinics have a similar approach. It's getting to know who their patients are, being their patients, and having champions within communities to derive and deliver creative and effective ways. And we try and support and help them achieve those goals. So a couple examples of what our members have been up to is Mountain Comprehensive Healthcare in Whitesburg. They have a van, that's this picture right here, that has traveled across Letcher County in that area, bringing vaccines to people where they are to help getting it done. There's been lots of testing. Everyone from Park Duval, you all had Ann on earlier, with Park Duval and what they've done to help create access to testing and to vaccines, and then all the way to Western Kentucky. There are many counties that don't have hospitals, and the testing is available in our member centers. And then taking it a step beyond, doing the care coordination. If you have a patient that comes in, taking the opportunity to get them up to date on services that were delayed or missed during the pandemic, and also providing one-on-one counseling to support those patients and help them overcome the illness. We also, like as I said, we work with partnering with a number of different organizations. We have been a part of the Take It From Me ad campaign with the Foundation for Healthy Kentucky. That's currently being revised to address issues that are being experienced this fall as they've kind of morphed from when it was initially conceptualized in the spring. Department for Public Health is a great partner, as always, with getting up-to-date information to our members. We have roundtables where it's a coming together or a meeting of the minds of and helping to do problem solving, how to best use school clinics when school's not in session, how to best, like I said, break up those large batches of vaccines so that we're good stewards, but then we're also not missing the opportunity to get a shot in the arm. And then we also, as I said, we have we're the Kentucky's primary care association for community health centers. And it's important we're to be stewards of the American Recovery Plan grant. And we have a project, it's called Stay in the Game, social media campaign. We have a care coordination effort to help do chronic care management and improve on missed wellness visits. So here, actually, if you'll give me a couple seconds, I'll show you the Stay in the Game.
Do your part. Get your shot. For your teammates.
For your coaches.
For your family.
For the love of the game.
Your team needs you to stay in the game.
Find a COVID-19 vaccine near you at vaccines.gov.
In that
Stay in the game.
In that messaging, we're using geofencing and all kinds of really cool ways of using media to help reach populations that message might resonate with. here are a number of different links of programs that we've been doing to help. There's an example. There are different examples of what clinics have been doing. We've realized that it's really important to have champions within these communities and who, like I said, know their community and know what works. And so these examples on our Facebook page show across the state what's working. And then this again is showing all sorts of vaccines. It's not just limited to COVID, but we also have efforts that have, about childhood vaccines and flu shots and HPV and whatever vaccines are age appropriate and clinically indicated. We want to have access to those. And this is one more video that I think you all might enjoy, just showing an example of a clinic creating access at a different point.
The Lexington Public Library Village Branch on Versailles Road is one of the locations where Health First Bluegrass is hosting a COVID-19 vaccination clinic. The clinic is on Mondays for the next several weeks. There's no cost, you do not have to have insurance, and there's no appointment necessary. Clinicians from various Health First teams, including translators who help bridge language barriers, are volunteering for the vaccination clinic assignment.
We've had a lot of big events here in Lexington. The health department has been great getting the bigger events. UK's been out there getting those. But we know for our communities and a lot of our patients, it's very difficult to get in to where those locations are, the hours that they are. So we wanted to make sure, working with our community partners, that we were popping up in sites that were easily accessible, removing some of those barriers around transportation, hesitancy around the vaccine, and getting into some smaller offers for vaccinations for our community and patients.
Well, we've heard in the data, certain populations that have not had access or it's convenient to get to the bigger sites. So we wanted to meet them where they are here in the community.
Health First Bluegrass is also hosting COVID-19 vaccination clinics at Shiloh Baptist Church on East 5th Street. Those are on Wednesdays for the next several weeks. With the Kentucky Primary Care Association, I'm Doug Hogan.
So that's just another example of what we're doing to try and help our providers provide healthcare. And now, did I stop sharing?
Yes, thank you so much for that presentation, Molly.
You're welcome. I hope I didn't rush by too fast, but I was trying to get it all in.
No, I understand. We have a couple minutes for audience questions. And so I've looked through what the folks wanted to know more about. And so some of the things that stick out for me is, as you all have talked, you've really, the core of the conversation that you've had is really different ways to create trust and messaging among folks. And so we've had some exciting things happen this week where it looks like the vaccinations for youth are going to open up, for younger populations are going to open up sooner. So given all these lessons that you've learned and what you know about the state of Kentucky, what do you think our best next steps are to ensure that the younger population, once that opens up, are more likely to get vaccinated? You can go in whatever order you would like.
Well, one thing that I think is really awesome that we, throughout the history of vaccines, we didn't have before is the Kentucky Immunization Registry, which really helps manage the information about where people are getting vaccines so that there's more comprehensive continuous care, so that if you go to Walgreens or if you go to the library or wherever you go, that information doesn't disrupt your treatment plan, so that that information is accessible and that the best care can be delivered. So I think that promoting the idea of getting vaccines whenever and wherever you can is supported and can be facilitated by the Health Information Exchange to make sure that doses aren't duplicated and that the best treatment is consistent across providers.
Thank you, Molly. Dr. Herrington or Dr. Krueger?
Molly, I think that you bring up really important points in managing the data so we understand where there are areas that are are served well, or underserved is really important. I think that what we've learned from the pandemic that we can build up on is mass vaccination at the period of crisis worked really well for getting large numbers of individuals vaccinated very quickly. And as the pandemic has moved along, we recognize that trusted professional is very important. I see some questions in the box about, physicians being the most trusted profession. Recent surveys tells us that the nurses are the most trusted professional and pharmacists are second. And pharmacists have moved up since the pandemic because they've taken such a key role in vaccination in pharmacies, and mass vaccination sites, et cetera. So I think that we continue to build upon those trusting relationships with every patient interaction. Kentucky Department of Public Health has worked with dental hygienists, with dentists, with opticians, with occupational therapy, with speech therapy. So if you're going to get your occupational therapy, there's an occupational therapist that you trust that's helping you rehab from your stroke, that's asking you about your vaccine. That as you get your teeth cleaned, that someone is talking to you about, after you get done here, did you know Walgreens 2 blocks over is offering the vaccine? We also know that messengers come in different forms. And so the community health worker that Molly spoke about, the religious connection, the community individual. So there's lots of messengers. We're all messengers. In our long-term care setting, we know that sometimes it's the chaplain or the cook in the kitchen that has been there for 25 years, that knows Mr. Jones likes peas on Thursday, that can have those influential conversations. So I think we need to know our population and then build upon the messengers that are in place.
Thank you.
Yeah,
go ahead, Dr. Krueger.
Yeah, I don't want to presume to people have boots on the ground here in Kentucky. I don't want to presume to know what's best for Kentucky, and that's how the question was posed. But I think what Molly and Amy were saying makes a lot of sense. Get involved in communities. We're going to need a lot of small-scale local clinics and other opportunities moving forward, and I think that is going to be the way forward. I think, Amy, you said it right. These big, massive vaccination clinics, we might have a couple to kick things off, but it's really going to be about getting in the community and getting community members as well as trusted other people involved. So the word has to get out. Access is still a big issue right now.
Dr. Krueger, I really like how you brought in some, national perspectives to Kentucky. And I like also how you said you don't want to presume folks on the ground in Kentucky. There's a lot to learn that we have from national perspectives and things that have happened. The thing that stuck out for me predominantly was the idea that if you can provide some more confidentiality, you might get more folks involved. And then Dr. Herrington and Molly, your discussion about how to incorporate not just physicians, but other providers into that conversation, including things like parents to parents, folks that are really liking of the folks who are really hesitant to get the vaccination. I would love to ask you more questions, but we are at the end of our time. So I want to thank all of you all for your contribution today and let you know it's given us a lot of thought for how we move forward in being successful in addressing the pandemic and other immunization issues within Kentucky. So thank you very much.
Thank you for having us. We appreciate it very much.
Thank you.